Continuing to look at anatomy with respect to movement as the central portion of our network of meaning or of our semantic network, we look at hip internal rotation, or if you prefer the term, hip medial rotation. Our objectives are to have a specific discussion of what hip internal or medial rotation happens to be with respect to planes and axes, have a general discussion of the muscles that generate the motion as well as the neurovascular bundle, and then a general discussion of the areas to assess and treat should hip internal rotation issues be suspected by the patient, or suspected by the practitioner rather, or reported by the patient. So we look at our quick review of planes: the sagittal plane, 50% cut of the body left to right; the horizontal or transverse plane, 50% cut of the body top to bottom; the frontal or coronal plane, 50% cut of the body back to front. With your axes being perpendicular planes, the sagittal plane has a horizontal or transverse axis, the horizontal or transverse plane has a vertical axis, and then the frontal or coronal plane has an anterior to posterior or posterior to anterior axis, depending on the terms you like. With respect to hip internal rotation, with respect to the anatomical position, so the legs generally straight under the body with the toes pointing straight forwards, what you're going to see is movement of the thigh towards the midline of the body. So the toes in totality would point towards the other side of the body or towards the midline of the body. That movement is going to be occurring in the horizontal or transverse plane about a hypothetical vertical axis. The hip, being multiplanar and multi-axial because it's a ball and socket joint, doesn't have these axes. The muscles generate the axis. Now, as we discussed when we were talking about external rotation, these terms for movement, although we're generally going to refer to them in the cardinal planes, internal and external rotation of the hip can happen essentially in any plane or in between planes, because you can position the thigh in a variable position and still have it turn towards the midline of the body or away from the midline of the body. So you can stick the leg straight out in front as if you were doing a front kick. And this is going to now, the internal external rotation would now occur in the coronal plane. You can stick the leg straight out, and now it's going to occur in the sagittal plane. But generally speaking, we're talking about the anatomical position, the leg straight under the body. Hip internal rotation would be movement of the thigh towards the midline of the body, so the toes would move towards the midline of the body, and it's going to happen in the horizontal or transverse plane about a hypothetical vertical axis. As far as the muscles that are going to generate this, you're looking at the anterior fibers of the gluteus minimus and the medius. You're looking at the TFL, the pectineus, and the adductor magnus, but primarily the pubofemoral portion of the adductor magnus. What this then suggests is that you're going to have to more or less go at least from the top anterior portion of the greater trochanter for the anterior fibers of gluteus minimus and medius. You're going to have to get the TFL there too, so you're going to have to kind of run around the front portion of the greater trochanter, the pectineus, and the adductor magnus. You're looking a little bit more at medial compartment of the thigh. However, because of the neurovascular bundle, so with respect to the gluteus minimus and medius, you're going to have to think about the superior, rather, I believe it's the inferior, no, the superior gluteal artery. You're going to have to think about I believe some circumflex femoral arteries for the TFL, and then for the pectineus, I believe it's obturator artery, but I may be wrong. And then the adductor magnus, you're looking at maybe some contribution off of the femoral artery, but also off of the obturator artery. So you're considering, with respect to the vascular bundle, you're going to have to run around the trochanter, at least primarily for the gluteus minimus and medius. You're actually going to have to go to the backside of the trochanter for that. Then you're going to have to look at the anterior portion of the thigh, the medial portion of the thigh as far as soft tissues are concerned, and the inguinal region, and to some degree consider the lumbar column as far as possible changes to intra-abdominal pressure on the abdominal aorta, and then the common iliac, and how it splits off there. As far as the neural side of it, lumbar column again, sacral or pelvic region again, so lumbosacral plexus, depending on the particular nerve you're talking about, or the particular muscle you're talking about. Now you have to consider the posterior region of the pelvis. So coming around the trochanter again, superior gluteal nerve, you're going to have to think about the femoral and obturator distribution. So you're thinking about the anterior soft tissues of the thigh, the medial soft tissues of the thigh, and the inguinal region again. So this then allows us to make the consistent case that if you are paying attention to your motion assessment findings, you'll behave accurate to the problems at hand, as opposed to chasing the neurovascular bundle. So knowing the neurovascular pathways has benefit to you, but your primary determinant of appropriate treatment is motion assessment findings. So if a large motion doesn't work appropriately, in this case, say hip internal rotation, or it prefers internal rotation and will not externally rotate, then you're going to have to consider this general region. But if you treat based on your findings in either gross motion identifying smaller areas or smaller subcomponents that are not moving as they should, or yield to soft tissue or yield to pressure based on soft tissues, you will perform your treatment based on identified problems as opposed to chasing the neurovascular bundle. To whatever degree a lack of motion in a particular region has an impact on a neurovascular bundle or a neurovascular structure, changing the motion is the thing that's going to allow the alteration of the function of the neurovascular bundle. So if you work on the motion, you're behaving appropriate to what you identify and appropriate to the situation at hand, as opposed to just assuming that if you treat the neurovascular pathway, that something magical will happen. It is only the relationship between mechanical discord and alteration in function of the neurovascular bundle that we can deal with. So if we chase the neurovascular bundle, we probably won't find it appropriately. But if we chase the motion problem, we'll behave appropriate to the situation at hand with respect to the patient. So as I noted, with respect to areas to consider for assessment and treatment, the lumbar column, neurovascular bundle, the inguinal region, neurovascular bundle, the posterior soft tissues of the thigh. Really more so you're looking at the posterior soft tissues of the pelvis. So you're considering the posterior aspect of the greater trochanter, the anterior region of the greater trochanter, and then the anterior and medial soft tissues of the thigh. As with anything, when you're dealing with the lumbar region as far as the neurovascular bundle, rebound tenderness in the abdomen is an immediate red flag. Possible visceral pathology, you don't need to know what, you refer that out. A known fracture or a known tear, you do not treat, that's a red flag. You can treat the patient, but you don't treat the fracture or the tear. Suspected fractures or tear, you refer out. So any of the regions that we noted, suspected fracture or suspected tear, you refer out. If there is no tear or no fracture identified, you increase the confidence with which you're willing to treat the patient in the region. However, you're still cautious, and you generally are looking at these regions for motion dysfunction. But again, known fracture, known tear, do not treat the area. You can treat the patient. Suspected fracture or suspected tear, refer out. If there is no identified fracture or tear, you increase the confidence with which you're willing to treat, but maintain caution.